Hello, everybody. All a little bit dark on me at the moment because of the sun setting and the light outside. That'll change shortly. It's always a bit weird when you start the Facebook Live because you sit here talking to yourself and you're presuming that there's other people out there. So I'll just start. My name's Mark Magnusson. I'm a plastic surgeon. I am an associate professor in plastic surgery through Griffith University on the Gold Coast. And we're talking tonight about breast implants illness. Let me see. Might have connection issues if you're there. Let me see. Oh no, we've got one thumbs up. Yeah, you're there. I'm on. I'm on. Good. Yeah. Okay. I'll start again. Okay, so we'll start again. There might have been a connection issue to start with. So my name's Mark Magnusson. I'm a plastic surgeon. I work in Queensland. I'm in Toowoomba and on the Gold Coast. I'm an associate professor in plastic surgery at the Griffith University on the Gold Coast and do quite a bit of research, particularly around breast implant risks, problems, safety and outcomes. And tonight we're talking about breast implant illness, which is something which is gaining a lot of traction in the patient advocate and social media world at the present. And I guess the reason I'm talking is we had a paper published last week in the Plastic Surgery Journal, Plastic and Reconstructive Surgery Journal, that is available free online as a download if you visit the journal's website, which we have put up on social media networks. So if you want to actually read the paper, that's certainly the case. Now, I'm sure there are going to be a lot of questions, but what I'll do to start with is give you a little bit of a background about the problem and about the history of the research that's been done into this area, because it has been suggested since the 1960s that there may be a link between initially injectable silicone and later on breast implants and systemic disease. So I'll just define for you what systemic disease means, because it is an important thing, because we know that localized symptoms, that is in the breast and in the region around the breast, can be associated with recognized complications from problems such as capsular contracture, implant infection, implant migration, implant mobility, scarring, things like that. They can cause local symptoms. But systemic symptoms are things that are reported to affect other systems of the body. So, ones we hear most frequently in the literature and so forth are things like muscle and joint pain elsewhere. For instance, localized shoulder pain could be associated with capsular contracture, as an example. But hip pain, knee pain, things like that would be a more generalized problem. Problems with your digestive system, problems with the skin, problems with hair, things like that. These are the symptoms that are reported, and they're systemic and more generalized symptoms. So that's the sort of thing that is reported to be associated with silicone. Now, it is a very emotive topic, and I know that some people feel that they aren't being heard when they come with symptoms of breast implant illness. The important thing, we'll get onto the science in a minute, but the most important thing is that women with symptoms have real symptoms. They are real women, and they have real worries about how this impacts their life and their future. And so the single most important thing is that our primary focus is on the women who have the symptoms, because they need care and attention in a medical perspective. So that, I just want to put that right out there, right at the start, because when we start talking about the science, it can get emotive and people can lose sight of what the true focus should be, and that's helping people. So we'll talk about the science. So breast implant illness has had a number of names over time. Okay, originally it was called human adjuvant disease. Now, what that means is that an adjuvant is something which, when it's in the body, it allows the body's immune system to respond to other, what we call antigens, where they wouldn't normally respond in the same way. The old TB vaccination we used to get when we were at school or when we were travelling is an example. It's adjuvant, and it makes us respond to the TB bacteria in a way that allows us to be relatively immune. So the concept, even when it was mentioned, was that the silicone might be allowing the body to respond to other antigens in a way that they normally wouldn't, which then leads to an immune response. And there have been a bunch of things that have been suggested. But one of those things was thought that possibly it was subclinical infection. In other words, bacteria might be the problem if this is actually happening. It's had other names: silicone-induced human adjuvant disease, autoimmune syndrome induced by adjuvants, or Asia syndrome, silicone implant incompatibility syndrome, SIS. But with the increased voice of patient advocacy groups, it's taken on the name of breast implant illness, which is what we've used as the term in our paper. Silicon, that's silicon without the E, is the second most common element on Earth. Okay, it's 28% of the Earth by weight. Okay, silicon is not the same as silicone. Silicon exists as silica. Okay, and is composed of silicon dioxide. Okay, and it's known as crystalline silica. It's represented in various forms, including asbestos and talc, and it's different from silicone, which is manufactured from silicon with other elements to create a polymer called polydimethyl siloxane, okay, PDMS. So silicone is not the same as silica or silicon. We do know that silica and silicon dioxide, which is the native form, is quite inflammatory. It's associated with lung disease, associated with miners and stonemasons, and certainly that was one of the areas that made people start to think, hang on, can the silicone also be initiating some sort of inflammatory response? A lot of stuff was done, and not a lot was really found to support that in this different form. So when we move on, it originally in the 1960s, liquid paraffin, modified petroleum products, not quite Vaseline, but that sort of thing, and then later liquid silicone were injected, particularly through Japan and Asia, as facial augmentation, much as we use fillers these days. They were also used in the breast for the same process. And what was found was in these, with these injections, there appeared to be an increase in autoimmune disease in some those patients in relatively small communities where the number of patients presenting with those diseases seemed more than they would anticipate. The same process was developed in an animal study, and at the end it was felt that there may be some association between silicone and as an adjuvant to make other things react. Now, it wasn't until the 1980s that there was a feeling that this may be occurring in association with breast implants. And in fact, the first series of patients was identified in Australia, in Sydney, and then the year after in America, and they were all published. But we're talking about groups of 2 or 3 patients. And this is one of the problems with all the science, is it's been a problem of methodology. While a lot of work has been done looking into a potential association between systemic disease and silicone breast implants, we've got small sample sizes. To put this into perspective, last year globally may have been as many as 1.5 million women getting implants. And we're talking about studies on 2 or 3 people. So the conservative estimate is that just with textured implants alone, there might be 35 million women in the world with breast implants without really considering reconstructive patients. So that's as many as 60 million implants. And again, we're talking about study groups of a couple to a few, as many as 100, but in the scheme of 60 million implants and 35 million patients, it's small. So it's hard to get a lot of evidence that really backs up a scientific discussion. And that's where a lot of the argument and disagreement occurs, because we've got, not only we've got small numbers, but we've got some instances where it's been suggested the symptoms might take 20 years to develop. So it's very difficult with something that is rare, uncommon, and takes a long time to develop in a patient group where we don't have good follow-up. So it's very difficult to be able to say there's the smoking gun. And on top of that, there are often potential confounders with the study. For example, it might be a study based on patients referred from a rheumatologist. In other words, they already have disease, they've seen patients, as opposed to a whole collection of patients who might just be turning up for implant revision or implant check. So a lot of that sounds technical, it sounds like a cop-out, but as I said, I want to outline the science, but I don't want to focus on the discussion of is it proven, is it not proven, or whatever, because as I said, the big focus is the last part, which is how can we help women who have real symptoms and real distress, and how can we get more information for them if what we have is inadequate? And that's where we're moving forward, or trying to. So through the course of the 90s, we did get some studies that had improved methodology. They looked at population-based studies. Even some of those were quite helpful, but still failed to really demonstrate anything. So using prospective studies which means patients starting before the implants go in, following them over time and seeing what the outcomes are and seeing if things occur. Look at population-based studies. One was a women's health study in America that looked at 87,000 women who had who were health workers, doctors, nurses, occupational therapists, physios, the whole, and then doing mail-out questionnaires and so forth. And then that was repeated when they looked at patients who had symptoms, because the first lot was self-reported, and then it went in to look at medical records, which found that one of the problems was with that methodology is that self-reporting tends to inflate the incidence by about 4 times when compared to actual medical examination and assessment. So there's just so many weaknesses that the literature isn't overly helpful. And that's where we are, because you've got so many studies, some refuting a a potential association, and other studies are suggesting that there's a possible association. So the debate rages. But when we look at what's happening for women, which is where we really want to focus, so women who are affected, they come in generally in 3 different groups. So there's women who feel they have, and as I said right at the start, what we want to do is firstly define who's got localized symptoms and who has generalized symptoms. So we're talking about the systemic symptoms, the systemic or generalized symptoms that are in areas well away from the breast that would not be expected to be affected by a breast implant. So when we look at those women, there are 3 general groups. The first group is women who, if you investigate them, they have no indications that there is a rheumatic disease, so like fibromyalgia, or mixed inflammatory arthritis, things like that. So they're rheumatic conditions, rheumatic meaning joints. And then there are and autoimmune disorders, so they're things like scleroderma, SLE, multiple sclerosis, rheumatoid arthritis. So these are well-recognised conditions. Rheumatic diseases and the autoimmune diseases have very set criteria for diagnosis, which you meet or you don't meet. Okay, so the 3 groups are women with symptoms who don't meet the diagnostic criteria for either rheumatic or autoimmune, and women who have a rheumatic condition, fibromyalgia most typically, or women who present with an autoimmune disease, and systemic sclerosis, systemic lupus erythematosus, scleroderma, these sorts of things. So even though the studies, even though the literature isn't robust, as we've said, or as I've said, it does give us an indication when we look at the numbers of studies that are there investigating and following women through the course of assessment, explant, and then seeing how they go with their symptoms. And what the literature will suggest is that if a woman with these symptoms has not met the requirement for a rheumatic condition or for an autoimmune disease, they have a very good response to treatment. 83% improvement in physical symptoms and over 90% improvement in any psychological problems associated, anxiety, depression, those sorts of things. Okay, so for women who don't meet the diagnostic criteria for recognised diseases in the rheumatic and autoimmune spectrum, they have a very good response to treatment. Okay, and this is the vastly overwhelming number of patients. So when you have patients who say, I have these symptoms and so forth, most of them are going to fit into this category. And most of them appear to have some benefit, okay? If we then move on to category 2, okay, so that's women who have their implants, have their symptoms, and have met the requirements for diagnosis for a condition like fibromyalgia, a rheumatic disorder. When these women have their explant, they tend to have a honeymoon period which may go for 6 or 12 months, but the symptoms usually return. The most difficult category of patients is the 3rd category, and that's those with recognised, diagnosed autoimmune disease. So that's the patients who have scleroderma, SLE, rheumatoid arthritis, myasthenia gravis, multiple sclerosis, thyroiditis, a whole bunch of conditions. These patients, in general, have no improvement in symptoms with explant surgery. Now, these two later groups, type 2 and type 3, are the minority of patients, but they still make up women with these symptoms. And so it is very important that when women present with these symptoms, that we fully assess them, investigate them. We determine firstly whether they're in the localised group or the systemic symptoms group. The localised group, capsular contraction, things like that, we have good information. We know how to manage that, and those patients do well, okay, by and large. So, they can be more complex. If you've got an implant rupture and it's extracapsular, that can be more complex than someone who's got an intracapsular rupture or a capsular contracture, but we've still got things we can do. We know what we're doing. So that's the first category. That's localised symptoms. Now we go to the systemic symptoms. Those without rheumatic disease, those without autoimmune disease, largely are going to have benefit from surgery or implant surgery. But the next question that comes to all of us is, so how do we test for breast implant illness? Well, that's the thing. We can't. As I said, I don't want to get hung up on the scientific debate about what constitutes proof of a disease, but I want to focus on the patients. So the debate is still ongoing about whether there's an association between silicone and this collection of symptoms. We know that patients with breast implants, if they have localised complications, get better. And one of the difficulties is with breast implant illness is that it tends to be a catch-all phrase that captures all patients with issues after having breast implants, and that includes those localised patients. As I said, we've sort of got an indication in the literature about how different groups of how patients can be divided into different subsets. They get managed differently according to those subsets, or at least the advice is different. I still see patients who have defined autoimmune disease and they still will say, I still want to have my implants out because by a process of exclusion, I've avoided other things. And I just feel that I'll be better without my implants. And there is no doubt, let's remember, breast implants are not life devices. They will all require revision. And while the vast majority of patients will sit comfortably with their implants for very long periods of time, for some women, implants don't turn out to be the panacea that they appeared they were going to be. And so it's a really useful thing for us just to recall that not everyone sits comfortably with an implant, even though most will. So having an implant removed because you feel you're over your implant, you don't need them anymore for whatever reason, that's a perfectly valid personal decision. But according to different category of patients, it may not help symptoms. Okay, so that's an important thing. But as I said also, the science isn't strong. These three groups I've talked about are suggested to us in studies of small size. So what we want to do is work forward. We want to try and find some more answers. Okay, from a scientific perspective, we need to retain an open mind. It was 20 years ago before we heard at all about breast implant-associated anaplastic large cell lymphoma. And at that point, it was, whoa, isn't that amazing? It was 10 years ago that authors in Australia were saying, hang on, this seems to be more frequent than we anticipate. What's happening? And people were still saying, well, there doesn't appear to be an association with implants, and it's only more recent with dogged research and going through numbers that we've been able to get to the point where we are currently, where we know that breast implant-associated anaplastic large cell lymphoma is actually associated with having breast implants. Further, we've been able to define the types of implants that are at greater risk than others. It's took 20 years of understanding and research to determine that. The same with bacteria related to capsular contracture. It took 20 years before that was defined as a process and recognised. So, you know, we have an open mind. The science doesn't support that association at the moment, but that doesn't tell us what we're going to be thinking in 10 years or 15 or 20 years. But to get more answers, and it still may be an answer that there's no association, but we need with better science. You know, so, but if there is an association, what we need to do is set up studies at this point which will allow us to collect information prospectively that's going forward. So we capture all the symptoms firsthand before the implants are out, and we follow people up afterwards, looking at their symptoms, seeing who gets better, seeing who doesn't get better. They need to be investigated before the surgery. Look at the implant. Is the implant ruptured? When this was first described, it related to silicone injections and ruptured silicone implants. Implants don't rupture nearly to the same way, nor does our gel spread in nearly the same way as cohesive implants. So it may be that it's a different, who knows? But by setting up proper research going forward, we can define more accurately how individual women might benefit from surgery. As an example, someone coming along into our study, we do the investigations. Hang on, you've actually got scleroderma. My first step will be when a rheumatologist involved to look at you and give you some feedback on scleroderma. Okay, we may still end up taking out those implants, but you need to have a full package of advice, not just a flick and click, off you go, problem done, operation over, away we can move on. It's about identifying, examining, investigating and watching to see how we go so that we can give the next generation of women with breast implants better advice, because this has gone on for 40 years in association with breast implants for about 36. It's gone with respect to injections into the breast since the 1970s in Asia. So this is a big problem. So some of the questions we see, okay, I got a few. I'm just going to have to look at them and load them up because Trish was able to send in some questions earlier, which people had sent through. So first one, there's a question from earlier. Does it relate to saline implants? Well, silicone, medical grade silicone is different from industrial silicone, okay, in that it has fewer additives, accelerants, and products that are mixed in with the important chemical ingredients that make the silicone itself. So it's a purified form, if you like. And it's available in three forms. There's a silicone liquid, okay, and that's like honey or molasses. It's not honey or molasses, but it runs like honey. It's oozy, it's sticky, it runs, it doesn't just drip off like water, it sticks to everything. The second form is a silicone gel, and they're like the insides of our implants, okay? So we used to call old generation implants liquid gel implants, liquid silicone implants, okay? Now we talk about cohesive gel implants. And then the final form is the elastomer. It's rubber, okay? So it's the outside surface of an implant, and it's other medical devices and things like that. Now, one question, can saline implants do this? Well, in theory, a saline implant has a silicone elastomer outer wrapper, okay? But it isn't something people talk about with saline implants, okay? Which again is something that says, is it silicone or not? You know, because silicone is still with a saline implant, yet we don't talk about it with that. Okay, so let's just look up these questions. So one of the first question I got was, if a woman with implants is identified as having BII and she is able to have her implants removed, does it fully get rid of the disease and or symptoms, or will she have it for the rest of her life? As I said, it comes down to the category of patient. Diagnosed rheumatic conditions are diagnosed rheumatic conditions. Diagnosed autoimmune conditions are diagnosed autoimmune conditions, and those diseases have their own natural process and natural history. And removing implants doesn't alter those. You may get a temporary improvement or a short-term improvement for patients with the rheumatic conditions like fibromyalgia, but in general, those symptoms come back. The autoimmune diseases, there doesn't appear to be any alleviation of symptoms unrelated to the presence of the implant. The symptoms of the autoimmune condition continue. For those women who have neither of those conditions, the studies would suggest an 80+% improvement in physical symptoms and an over 90% improvement in psychological well-being. So if we group all patients with breast implant illness in a pie and cut it up, if we don't try and break it down into individual patient groups, a lot of research in the literature will suggest around 60% in women. So 6 out of 10, 3 out of 5 women will get benefit from surgery, and 2 out of 5 will not feel like they've had benefit from surgery. But they may still get a psychological benefit because they're no longer concerned that it's the implant problem, and they know that they've at least given that a run and to see if it's causing or contributing to the problem. So there may still be a psychological benefit even if there's not a physical benefit with symptoms. So next question, are there cases where a ruptured silicone implant is not able to be fully removed? Is part of the implant or part of the silicone itself left inside somehow, and how will that affect her long term? And how will the silicone leaching into the body, how about the silicone leaching into the body? Can it expel itself, or does it kind of sit in the body forever? The short answer is it kind of sits in the body forever, okay? The old liquid silicone implants, when they ruptured, they were oozy like honey. Because it was low size particles, it was able to more frequently get through the capsule that the body makes around the implant and then get into breast tissue. Now, for those patients, it's a very difficult problem. If you've got extensive extracapsular rupture, which is what we're talking about, if you've got extensive extracapsular rupture, which thankfully we see far less frequently now, then you've got a bit of a quandary. For the vast majority of patients, you'll have fine bits of silicone into breast tissue around the capsule, which is seen radiologically, as in on ultrasound, and we take out the capsule and the implant, and that will take away the source of the silicone, but not the small amount of silicone that has still been able to seep into the tissues. In general, we don't take that. It doesn't cause ongoing problems for patients who present with extracapsular rupture of their silicone breast implants. If we take out the source of the rupture and the source of extra problems and leave the bit that's finally through the tissue, sometimes we'll take out lymph nodes if they're large and sore, but by and large, the rest of the tissue is left behind and it settles and doesn't cause ongoing problems. To take it out might mean a mastectomy. So even if there was concern that that silicone silicone might cause ongoing problems, even though historically we don't see that. There's a very substantial step from removal of implant with capsule and mastectomy. So even if it went on to cause problems, my feeling would be that for the majority of patients, now everyone's individual, but you would be saying, I'm going to leave that little bit behind, because we experience, with a history of experience with these things individually and as a craft group in plastic surgery, we know that the majority of settles down and doesn't cause ongoing problems, and it's going to give us the best aesthetic outcome. Those options for addressing ongoing problems remain present at a later time. But as I said, there's no hard scientific data that would support the disfiguring approach to doing a mastectomy, unless you've got such extensive extracapsular spread that you need to take it because they're hardened lumps. And we do occasionally see that. We used to see it more when those implants were still being inserted. But it's now, in Australia, it's now almost 20 years since we've seen a lot of those going in, certainly 15 years since we've seen a lot of those types of implants going in with silicone gel, and even longer since we saw the silicone, the liquid gel implants with the flimsy capsules that used to rupture. They were the ones that went in the 1980s. They were the ones that Dow Corning produced. They were the ones contributing to all the original problems that led to the silicone moratorium in 1992 and 1993 in the United States, that led to the banning of silicone at that point, and a micro-focused approach to this particular problem. Through all of that, they still came out with no evidence to show an association. And it's not a conspiracy theory. These were governments, law courts looking into these things, epidemiologists, immunologists, the FDA, the Canadian government's health authority, the British health authority, all had independent task forces to look into this. Because I realise that I'm a plastic surgeon. I use breast implants. And some could easily say that, oh yeah, well, I'm conflicted. I'm trying to earn my money, pay my mortgage, and put my kids through school. You know, so and I accept that there is a level of skepticism about some of the information that you hear and read, but it has been repeated again and again and again and again. And then we look at the track record of the people who talk about it. So the group that we've got together to talk about this paper, we're the same ones who have focused the spotlight on breast implant associated anaplastic large cell lymphoma to get real data about incidence, risk, and implant types that are at greater risk and so forth. So you can say that there's a level at which conflict could exist, but at the same time, you can look at the track record of the people who are talking it, because we've not been afraid to point the spotlight on breast implants and ask hard questions and get even harder answers. We developed answers that people didn't want to hear. And so we're trying to now look at this in exactly the same light. How do we get more information? How do we try and find out, with broader scientific evaluation of the problem, is there a potential association? That's one side of it. That's not going to happen, if it happens, for many, many, many years. More importantly, more short term, and as I've said a number of times, let's focus on the women, because the women are the ones suffering. The women are the ones with real symptoms. They're the ones concerned about, is it going to affect me? One of these particular questions, and I'll jump forward, where was it? Was a question, can breast implant illness kill me? I mean, there's a huge amount of psychology and concern and anxiety associated with that. The bottom line is, you know, at this point, we've got no evidence of that. But again, breast implant illness does tend to be a catch-all phrase. So if you look online and in some of the patient advocacy sites and so forth, you'll see breast implant-associated anaplastic large cell lymphoma is listed as a symptom of breast implant illness. It is not. It is a distinct disease. And of all those millions of women who've had breast implants, 35 million with textured breast implants, there are 17 million women worldwide who have died of breast implant-associated anaplastic large cell lymphoma. But that is not breast implant illness. I'll go back to the questions. I've heard that breast implant illness is not recognised as a thing by a lot of surgeons. Is there a test? No, there's no test. There are tests we do so that we can categorise and make sure there's not another definable medical condition present which might benefit from treatment on its own right, separate to what we need to consider with the implant. Okay, so it doesn't mean that there's not something else happening as well, but there's no defined pathological process, there's no test that we can do, but we still need to assess to exclude other conditions. And what about a lot of surgeons not recognising it as a condition? Some people are very dogmatic, and you'll get that in whatever walk of life you face people, whether it's bus drivers, checkouts, whether it's medical, whether it's legal, whether it's whatever. If you look at and this is why I tried to stay away from the discussion about the entity of BII, because if you look critically at the science, there's not enough evidence to confirm it. But we want to focus on the women, not the diagnosis. So some surgeons, and I've heard them do it, say, no, breast implant's not a thing. Breast implant is not a thing, it's in your head. I think that's a disastrous comment. Sure, science doesn't support it being an entity, but you have real symptoms. Let's look at what we can do and what advice we can give you and how we can manage those. And at the same time, can you join the studies so that we can recruit more information, get more data, and eventually have more answers? So that is an approach I'd like to hear more often. And certainly the majority, and there are a large number of plastic surgeons around the country who are aware of all this information. I presented this information at the Breast Masters Symposium last year in Sydney to a room full of almost 400 plastic surgeons in Australia and New Zealand. So this is the majority of plastic surgeons doing breast implant surgery in the country that heard this data. It's now published. Okay, so I would hope that we see fewer people saying, dismissing it offhand and focusing instead on the women. So if a patient presents, can it be fixed by implant removal? We've talked about that. Are there particular patients at more risk with developing BI? We don't know. We haven't got that level of data because the problem is we're only cherry picking patients who are presenting with the problem with no understanding about how many women in the general population have got their implants. So therefore, how many are getting the symptoms? In Australia, we have the Australian Breast Device Registry, which is now collecting the data on patients having breast implant surgery, both when it goes in and when it comes out. And in due course, we'll have a far greater understanding of exactly how many patients are getting surgery. And then we'll understand the base level to which we compare these numbers to. Because we could say, scleroderma has a rate of occurrence of, 2 in 1,000 in the general population, or 2 in 4,000 or something like that. In women with breast implants, over this period of time, we've been able to show that it's the same, or is it up, or is it down? But that's going to take years to generate information. So we can't say who's at greater risk, who's at less risk. Or, as I've said, we can't say whether there's a link without more information. For ladies who have implant illness, is there a special protocol that needs to happen afterwards? Well, there's no special protocol, but as I said, we started a study and we're recruiting, examining, then treating, and then following to see what the outcomes are. And if some of the blood tests are abnormal, then we'll repeat them afterwards to see if they normalise. If none of the tests are abnormal, we'll just follow the symptoms and see what happens with the symptoms and see if we can find out a way to give women solid information about how they're going to like to proceed. For why are implants still being done if this is possible? Well, as I've said, one of the problems is this. We've got 35 million with textured implants. Now, the United States is the place where the largest number of smooth implants goes in. The majority of the rest of the world is predominantly textured implants. So let's argue, say, 45 million women with breast implants total worldwide. We're still, if we have 40 million women without implants, we are going to have women with unusual symptoms. And if those unusual symptoms can't be explained, they're an enigma. For women with breast implants with unusual symptoms, the implant is being investigated to see if it's contributing, but we still don't have proof, definitive proof to show. And even in the small number of studies by a small one or two groups of researchers that have suggested that they feel there is an increase in risk, we are talking about rare conditions like systemic sclerosis going from 2 in a few thousand women to 3 in a few thousand women. So we're talking about a rare condition possibly being made slightly less rare. And even then we don't have proof. So now we look at the women who've got breast deformity, breast asymmetry, they've had breast cancer, or they feel dreadfully self-conscious because they're still getting their lingerie from the 20 section, and there's a lot of benefit for a lot of different women for breast implants. And there needs to be some sort of proven and identified reason to just discard. But as I said, this is a very emotive issue. And, but at the same time, these questions need to be asked and I'll answer them. So here's one from a lady. I've had implants for 8 years. Should I be worried? Have I got any problems? I haven't got any problems except for I get more headaches than I did before. Women with large breasts, now I'm not saying this woman now has great big breasts, but women with large breasts who present with breast reduction have typical symptoms, which includes headache, pain between the shoulder blades, pain in the shoulders, pain in the neck, and headache. So look, headaches are there for a lot of reasons. And yet it's entirely possible they relate to implants in this instance, but not because of BII, but because the breast might be bigger. And this is, again, an example, potentially, because I haven't seen this woman, I don't know this woman, and I don't want it to be too general, but this is an example, again, of how someone may feel they've got BII, and yet it's a localised symptom of breast implants or something different. So if you've had 8 years of good aesthetic outcome and you've still got a good aesthetic outcome, you're in the same group as the vast majority of women with breast implants. In general, 9 out of 10 patients in a good breast practice, 9 out of 10 patients are going to still have their implants at 10 years. Now, the rate of revision becomes more frequent after that 10 years, but there are probably over half of women still have their implants with modern implants. Probably over half of women still have their same implants at 15. But that's harder figure to define. So, but certainly once you get to 10 years, that rate of revision becomes more likely. So one of the things we're finding when we look at these women who come in for breast implant checks and breast implant, potentially breast implant revisions, if you ultrasound women with breast implants after 5 or 6 years, you'll find that when you detect an implant rupture, 2/3 of them have no symptoms whatsoever. Because we have gel in our implants that's like a gummy bear, or it's like the inside of a Turkish delight. A small tear in an implant, which can come from a bike accident, a car accident, or wear and tear, whatever, small tear in an implant capsule, that gel is cohesive and it sits there and does the same thing it's always done, even though there's a tear in the capsule, and the body capsule has still got it. So that's called an intracapsular rupture. Now, we would say for women like that, you've got, I would tell people, look, as long as there are no ongoing changes, in 12 to 18 months, sometime when it's less inconvenient, we could need to consider removing that implant and replacing it. But it's not an urgent problem. So at 8 years, if I was going to do anything and I didn't have symptoms, I'd suggest, look, an ultrasound might be a good idea for that reason. And if that finds nothing, then I would say keep going. There's nothing to be worried about at the moment. The last question I got, where can I go to get checked and how can someone even do a check? Well, hopefully you've already heard the answer to that, but look, specialist plastic surgeons are aware of this problem. A clinic with a big breast practice should be well aware of this problem and be able to assess your needs. Now, our study is slightly different, but any of our colleagues can reach out and say, I've got a patient, she wants to have those investigations, what should I do? And we can send those details, and your surgeon can organise all those tests and so forth if that's what you want to do. We certainly do have a centre in Sydney at Macquarie University, and I'm seeing patients in Toowoomba and on the Gold Coast that are affected by this this problem. But specialist plastic surgeons in general are able to assess you and go, is it localised due to the breast implant? And if so, how do I manage that? If it's a systemic problem or there seem to be generalised symptoms, what investigations should I do? How should I look into this further to make sure there's not a different disease process occurring that needs treatment in its own right? Okay. And then on the basis of those tests and your symptoms, how best do I proceed? Okay. And as I said, it's this information and this skill set are within the hands of your plastic surgeon. So that would be the first place to start. Okay. Yes, I see patients with this. And as I said, there's another assessment centre at Macquarie University with a colleague of mine and co-author, Professor Anand Deva. And yes, we can do it, but we can coordinate through your plastic surgeon as well. It's something that there's a lot of help out there, even though the energy level and stress level of the discussion would lead some people to think they are on their own. I can reassure you that you're not. Certainly, as I said, in my practice, in that clinic in Sydney, but I know of a number of plastic surgeons, and in fact, many have reached out to us on the publication of this paper to say, how can I help recruit patients, or at least if we're treating patients with this disease, how can we recruit their information to help with the study to give us better answers in the long term. So how and what is checked? How and what happens when we do a check? Okay, so as I said, the first thing is to try and historically work out what symptoms, what implants you've got, what's the status of their implants. We've got a number of ways. All implants are going to need revision. The first thing is there a problem? A physical problem, as in a structural problem with the implant? Is there an aesthetic problem with the outcome? Because the breast, for example, will age over time, and 10 years after, and maybe a pregnancy or two, the breast will be different. Okay, so all of these things need to be assessed. But from a symptom perspective, are the symptoms something that can be attributed to the implant, or are they more generalised? We do a whole battery of tests that look at the diagnostic indicators for autoimmune diseases and inflammation and things like that. We then do an ultrasound of the breast to look at the status of the implant. Because as I said, if nothing else, 2/3 of implants that are ruptured don't tell us anything. There's no symptoms. Finally, if we go through to surgery, we are sending the capsule that we take and we are analysing that. So we are looking at that to look for the presence of things like bacteria, inflammation, silicone, all sorts of things. Okay, so we're then going to be collecting all that information to analyse it as we get more and more data to see, because that hasn't ever been done. So are we going to find something new? We hope to answer questions like, if you have followed the BII discussion, patients ask for en bloc capsulectomy. Well, hopefully, the management of these patients in a number of different ways, if we can get enough patients involved in the study, hopefully we'll be able to do something and answer that question with authority. Do we need an en bloc capsulectomy or not? Or can we just reserve for those conditions where it is actually helpful managing the problem, like extracapsular rupture of a liquid gel implant or breast implant associated ALCL, which are different problems? En bloc capsulectomy is a very useful tool, but for a lot of patients, we've got a flimsy capsule and it's a difficult process and a traumatic process. And we can save people from morbidity if we don't do that unnecessarily. So these are some of the things that we're hoping we'll answer in due course. So I don't have any other questions. Perhaps a lot of people might look at this later as a non-live discussion, but hopefully you all felt like it was worthwhile. From my point of view, as I said, I would like women to realise that there are a large number of plastic surgeons who are aware that these symptoms are real, that the diagnosis is not, the name of the problem is much less important than the health of the women. And as plastic surgeons, we are doctors first, and we're here to care for you. So thanks, everyone. Without any other questions, have a good evening. It's hump day.